Morning, everyone. Thanks for showing up on this Monday morning. I know that there's a nice crowd because of our speakers this morning. So that's we'll have Dr. Abdelhadi introduce Tamara here in a second. Before that, I just want to outline a few things with respect to the Foundation research portfolio. Actually, quite an active month, September. Earlier in the month in Arizona, Kasia Ernowitz and many colleagues from the Heart Institute sort of took over the ELSO conference in the Phoenix area. There were several presentations, 3 posters and an abstract, and one of our first-year fellows also had a poster. So congratulations to that team. Ongoing at TCT have been several presentations. I think the highlight from TCT, as everyone probably knows by now, the surprisingly to me positive results of the Mitral clip study, where the treatment of patients with the mitral clip had a staggering influence on both survival and rehospitalization for heart failure. So I think that's going to be a game changer. And of course, we participated in that trial through the leadership of Paul, Suraja, and Mario. And then I think Paul has just published his nice book on structural heart cases and is handing that out to whoever wants to take a look at it. And Manos also on his manual of chronic total coronary occlusion. A few studies to highlight. We have the AEGIS trial for coronary syndrome run by Dr. Nickelbein, Transcend for peripheral artery disease, and ASAP-SVG, which is Dr. Berlach's study of bypass grafting and use of PCSK9 drugs. The gala is October 13th. For those of you that don't know that, we've tried to advertise that, and I think I'm going to pause now and have Dr. Abdelhadi join me on the podium so we can introduce our delightful speaker for this morning.
Thanks, Scott. Sorry for being so casual. I didn't know I'm doing this. So good morning. So I think everybody in the room knows Tamara. She's been here probably longer than most of us. Even if she didn't tell me, I would have known she's a farm girl from Minnesota. I mean, she just has that attitude and that spirit. All of us know Tamara as a fantastic clinician. All of us know her, and she's our go-to person on the floors. But I'm not sure how many people here know Tamara as a wonderful leader. I think John and I and many in this room know that, I always hear about the MHI spirit, and you can never think big enough and do big enough, and Tamara truly represents that. Tamara led our EP program through a lot of innovative things. The Cardioversion program, which is one of a kind, was her she fought for it. I thought it will never happen. It happened. I learned not to fight against Tamara. I know she wants to take over the world and do all kind of procedures in the EP lab. I'm nervous, but I have a feeling she'll do it. Tamara has been on our executive committee as the lead NP for a few years, and I think no one will feel offended if I said that she's probably been the most positive force, really a game changer in that room, and we're so proud to be part of a team that includes Tamara. So I know she gets nervous when she speaks, just a little bit, but I'm confident she's going to do way better than the Vikings. So.
That's nice. He doesn't set the standard very high. So there were 3 primary objectives really to take away from this talk today, and really the role of the advanced practice in identifying the practice needs within the gray zone, creating a systematic role to improve healthcare delivery. I want to make sure we identify innovative cardiovascular care delivery through optimizing provider scope of practice and scientific discovery as well as understanding. And then through this care, really identify guidelines for future directions of high quality and efficient care. So we commonly get asked, why did we start the program? And in all honesty, why not? Where does it say who can or cannot push the button, which all of you will know that's really the primary drive behind why I wanted to do it. A lot of this has been filled in since. But really nowhere did it state, and actually literally they said you can't, you're an NP, you can't push the button. And so we actually looked, and there is no specific medical license that says that you can or cannot push that button. Really all it spoke to was the number of supervised procedures needed to demonstrate your competency and really qualify for institutional credentialing, and then also the number of procedures to maintain that competency. When I started as a new NP, a preceptor had told me that most advanced practice start pushing for professional growth after about 5 years of practice. So if you look at it, Beth Hunt started EP in about 2002, and then I joined her in 2004. And then in 2007, Roxanne and I started the process to perform cardioversions, and it really wasn't approved until 2009. So it took 2 years to change the mind. So out of the objectives, really what is the role of the advanced practice in identifying practice needs within that gray zone and creating that systematic role to improve healthcare delivery? So we looked at really, wouldn't it be better if, you know, in previous talks I always referred to the MD as the weakest link, so we kind of removed that weakest link from the cardioversions, and really that was the words of Katsianis, to be honest with you. But technically that's not true. But is the MD the best provider to do the job, or are they better resourced to perform complex procedures, which is really what they're trained to do? So what if we could create a dedicated and streamlined service that patients can get referrals and better access to care? What if we could better identify patients who are candidates for advanced EP therapy, both invasive, non-invasive? Can we expedite patient access to care? And can we better prevent patients from falling through the cracks by getting them back for appropriate best practice follow-up? So to develop our Cardioversion program, really we needed experimentation with an innovative concept. Any innovative concept really requires practice collaboration with colleagues. We need the education support that allows expansion of one's scope of practice, but we also need our advanced practice team to really step out of their comfort zone. Then we need system support, not only from the electrophysiology team in this case, but also from MHI leadership. I remember going to the MHI executive committee and sitting there and explaining what we wanted to do. Our anesthesia partners, huge components with a powerful voice. The medical staff office and credentialing, hard to put up a program that you have no comparable to. And then as well as our prep recovery staff, convincing the nurses that actually an NP or PA can do it. So along the way, I found this paper, or this report that was released. I believe it was like in 1999. They released the Error is Human, Building a Safer Health System. Really, this was a report that described preventable hospital deaths from medical error, which, by mind you, has nothing to do with the Cardioversion program. But really, basically, they found that upwards of 98,000 people die in hospitals each year due to medical errors that really could have been prevented. That's actually more deaths in a year than, say, breast cancer. So, and the costs resulting from those errors were upwards of 29 million, or billion, sorry, per year. From this, they defined events, developed reporting systems, talked of individual accountability for reckless provider behavior, and really held organizations accountable for unsafe conditions. Those are all great things, but really what they missed most is that they missed the message of freedom from accidental injury is the responsibility of a system, and developing safety and patient care is more important than defining the error. So it may be part of human nature to err, but it is also part of human nature to create solutions, find better alternatives, and really meet the challenges ahead. So improving, here's the farm, I guess. I wasn't quite expecting the farm introduction, so sorry. Improving safety and care requires respecting individual and system abilities by developing a process that recognizes our strengths and our weaknesses and then really capitalize on those strengths. So really this requires collaboration and developing innovative programs through optimizing the scope of practice. And really this is at any level, not just at the advanced practice level. The Cardioversion program is not Tamara's. A lot of people say it's Tamara's program, it's that sort of thing, but really it's the electrophysiology team. A program cannot be built on one person, as then it's sure to fail, but you need a team in order for that to happen. So to do this, our learning would need to focus from the growth of an individual within a practice to the practice actually becoming a stronger system through growth of the team. So I found there this description of a gray zone. And really the gray zone is the space between all the disciplines and where we have the most opportunity to optimize patient care. True collaboration, not just between providers, but between nursing, administration, medical staff office, et cetera, whoever is in, everyone. Because it most often requires a change of culture and tradition, it also a lot of times can be the hardest to achieve. So in EP, we identified 4 gray zones. We've actually identified more, but they've let me act on 4 gray zones within EP. So and that's cardioversions, tilt table tests, implantable loop recorders, both placement and removal of those devices. And really advancement of the EP advanced practice scope of practice took true collaboration to optimize the care within this zone by developing the electrophysiology advanced practice knowledge as well as the system practice changes. So the medical system commonly has used the term collaboration to describe a hierarchical relationship and has traditionally been referred to as an interdisciplinary structure with an MD as the supervisor of the team. When really, true collaboration is defined by Linda Pearson as partnership based on mutual respect for one another's expertise, knowledge, and skills. And through this partnership, territorial issues then dissolve. And at that point, there's cooperative sharing of information and resources. Each provider feels jointly responsible for the outcome of those patients. And then care is given by the person who can best help that person at that moment. For example, if you have a patient who's coding, it's a patient that we don't know, but we step in to help and have a vested interest in making sure that that patient has a good outcome from that cardioversion or from that cardiac arrest. There's a story of a tilt table test that Sengupta always, Dr. Sengupta always gives me a hard time and brings back to. Many of you know Dr. Almquist. So he was our consult physician on the electrophysiology service, and really at that point he was kind of our true collaborator physician that would do these tilt table tests with us. And tilt table tests kind of came, it was, and this sounds horrible, but it was kind of the price we had to pay to do cardioversions, right? So nobody really wanted to do them because you sit there and you walk. It's similar to watching paint dry, but it gives a lot of information to the patient and is actually very helpful. So there was this young guy who came in. He had had multiple episodes where he had passed out and actually had chest compressions. And we're like, wow, you know, he's young. And so I do the tilt, and when we're doing the tilt, and these guys will contest to this, Dr. Almquist would call us weak if we put the tilt table back down before the patient passed out. So this guy's like going and finally went out, right? But the table won't go down. So like the button's not working. So we had to find the quick release, which then at that point we now have about 4 minutes of asystole, which Dr. Almquist to this day does not believe me. But then we had to start CPR to circulate the atropine, and Randy Johnson actually stepped over from the echo lab to step in. He didn't know that patient from Adam, but he was a part of the team that came in to help and make sure that patient had a good outcome. In 2007, Dr. Mary Noreen Walsh, she was the president of the American College of Cardiology, wrote of the need to focus on better models of care delivery. She describes that we're surrounded by talented colleagues, and it is integral that we recognize each other for our talents we bring to them. So collaboration is not determined by the independence of any one provider, and MHI really fosters this. How often do you see a provider walk into the next room and say, what do you think? Or Dr. Sengupta comes out of the EP lab with his tracings, all excited to show and share with partners what he found in the EP lab, something about an accessory pathway in an unusual spot. So we rely on other members of the care team to give best care to our patients, social workers, the pharmacists within the heart failure team. This true collaborative environment offers more opportunity for success. In contrast, a boss-dominated environment has been found to facilitate inefficient care where we risk becoming less beneficial for our patients. So successful residency programs, fellowships, our onboarding are all based on the collaborative concept. Through this collaboration, we teach what we have learned from experience over the years, but also realize that through change, we have the best opportunity for a good result if we practice in a collaborative environment. And as the saying goes, good decisions come from experience, which we want to teach. Unfortunately, that experience usually comes from bad decisions. So the greatest challenge within that gray zone becomes learning, using, and sharing that information better. And to do this, we really need to embrace the opportunity to see what we have to gain rather than what we may be losing. And then also through building a legacy of practice. So we use our past and current experience to give guidance to our next opportunity. Research is the perfect example of this. So by discovering cardiac depolarization, the idea of a cardioversion, a pacemaker, a defibrillator actually were able to be imagined. As our roles evolve and change, both at the practice and the organizational level, Delivering care as a team can then offer more opportunity for a system and individual growth. The cardiologist has more opportunity to develop advanced knowledge and innovative practice within an advanced practice scope beyond that of an advanced practice provider. It doesn't necessarily make the MD more important, but rather it takes advantage of what they're best trained to do, and in turn advances both the advanced practice as well as the MD's field of practice. So if we look at identifying innovative cardiovascular care delivery through optimizing the provider's scope of practice and mirroring that of scientific discovery and understanding, really what we're doing is we're taking what we know, learning from those along the way, and having a vision of what we have to gain. So experimentation. I chose the one that didn't involve alcohol. Most of it's, hey guys, hold my beer, I guess. But this is okay for a 14-year-old son to wear on his shirt. But identifying innovative cardiovascular care delivery through optimizing provider scope of practice really mirrors scientific discovery and understanding. It was through experimentation that indoor plumbing surpassed outhouses, which I believe we are all thankful for, as well as electricity being discovered. That experiment required seeing a situation in which we see gain. Then going after it is using what we know, what others have taught us, identify what has or has not worked in the past, and adding a touch of what we think might work. Through the legacy of work on medical experimentation and the theory of the excitable gap with Thomas Lewis, Bernard Lowen then was able to present work on cardioversions, and that actually changed clinical practice as we know it. Prior to cardioversion, the only option was medication, and a little tidbit, kind of crazy, but basically the medications, how they described it was basically they gave them in what they described as safe increments until one of two things happened. The arrhythmia terminated or the patient became toxic. So discovering the solution was a much longer process, but really defining cardioversion started with the discovery of electricity in the 1700s, and then over time, experimentation defined direct versus alternating current. It demonstrated that we can use anterior-posterior patches in place of a thoracotomy, and discovered usefulness of cardioversion beyond ventricular fibrillation. Looking at what we know. Discovering the solution for an advanced practice-driven cardioversion program was not near as crazy as a thoracotomy or flying a kite with a key on it, but took similar conceptual route. Prior to the cardioversion program, there was really no standardized regimen for anticoagulation. There was scattered cardiologist workflow. We would actually wait for the cardiologist to get done with their cardiovascular case before they would be able to come in and do the cardioversion or the EP or TE or whatever the case may be, and then see if anesthesia was available. And if all those stars aligned, then the patient had their procedure. Prior to the program, we missed patient follow-up. There was true variation in practice, and many times patients' primary cardiologist was not the one that did the procedure, and so the recommendations then were deferred as a result of that. And then the precious resources. You look at the cardiovascular, EP lab time, CVDS, anesthesia, bedside nursing. We did basically one procedure at a time in one room and no defined schedule of procedure time. We looked at what others have taught us. Dr. Hurl did a lot of great work and got the TEE integrated into the cardioversion procedure, so it was a single procedure that allowed the patients to present to one unit and receive one sedation procedure. Seeing what we have to gain, above all, really the whole idea was to provide the highest quality of care efficiently to our patients in a true collaborative practice. In addition, we got to develop professional expertise. We developed a program that pushed the boundaries that has now become tomorrow's standard or today's standard, and then really challenged the traditional provider role. So then we added a touch of what we think might work. So having an advanced practice care for patients scheduled for elective cardioversion procedures and perform the procedure, and this was a clear gray zone that we identified. It would lead to a change in culture, not just clinically in practice, but in view of the medical staff office, requesting providers, patients, staff. It also messed with territories and tradition by redefining roles. And again, not just within MHI, but also within Abbott Northwestern and Allina. And at that time, we had no other practice to compare to. So there were bits and pieces of advanced practice around the Twin Cities and outside of Minnesota that were doing cardioversion, but there was no true advanced practice-driven program giving no community or national standards. Trying to ask for privileges for that. So we started the Cardioversion program in 2009, and at that time we only did cardiac electrophysiology provider patients. And even at that, I'll pick on Dr. Melby, he still wanted to do his own. So we would accommodate because he didn't fully think that an advanced practice could do it solely independently. But within a couple of months, it was not uncommon for other cardiologists to ask us, and Dr. Melby handed it off pretty willingly. Then we formally expanded in 2013 to all of the MHI practice patients. This became the new norm as the advanced practice was supported now by anesthesia. All cardiac electrophysiology MDs were on board. The CV prep recovery staff was fully with us, leadership, and most of the MHI MDs. So the advanced practice cardioversion or directed cardioversion program really changed the standards of care at Abbott for patients undergoing cardioversion procedures. We worked as a team to deliver better care to our patients. We standardized the process and education given to patients prior to their procedure. Patients and staff were initially unsure of having an advanced practice perform their procedure to the point where we had the coordinators inform the patients that this was now going to be done by an advanced practice. We standardized the scheduling, and that included developing a checklist at the time of scheduling to ensure that the patients were ready for the procedure on arrival. We now have fewer cancellations because of inappropriate anticoagulation as a result of that. So patients arrive, they actually arrive to actually have their procedure. The timing of the patient arrival to accommodate our growing cardioversion program and being respectful of the cardiovascular lab, EP lab, vascular lab, as well as the MDA availability. Sarah and the third floor leadership was integral in helping to make sure that we were able to do more procedures, but also accommodate all the patients in third floor. The program also improved the efficiency of the cardiologists by putting them in a true collaborative role. We provide what, in describing it, Dr. Sengupta goes, well, that's like a full service evaluation. So patients with easier access to the cardioversion procedure as well as specialty practice. So patients will come directly from internal medicine and we'll actually see them for the first touch of the cardiology practice. The cardiac EP consultation, we can instantly get one of those anytime we need for patients with concerns that were identified or if the procedure was unsuccessful. We're able to focus care to look at advanced care options, antiarrhythmics, procedure-based care, or even just a rate control strategy. I believe in 2013, one of the first days that we did it, we came across two of our patients. One of them went for an atrial flutter ablation instead of a cardioversion, and the other one went home with a rate control strategy. They didn't have their cardioversion either. As much as we love to push the button, the truth behold is the whole idea is getting the best care for that patient. We were able to better align patients for follow-up and referral to appropriate providers and clinics consistently. And we teamed up with requesting cardiologists to carry through patients taking care into consideration. So there are some cardiologists who are really good at that dictation and putting forth what their thought process is, and we can help to follow through with that expectation for that patient. But given certain circumstances, as say a patient converts to a heart rate of 40, we may tweak or modify and work together as a team for what's best for the outcome of that patient. The program gave better understanding and opportunity to look at anticoagulation for patients undergoing cardioversion procedures. So we developed a community standard using best practice. The DOACs came to the market. There wasn't really any research on patients having a cardioversion with a DOAC, so we used drug half-life, expert consensus surrounding those DOACs as they came to the market. We changed the look of the heparin protocol for patients undergoing cardioversions, and that was with help of Dr. Bradley in the pharmacy. The program better utilized anesthesia and bedside RN resources. We now perform more procedures in a shorter period of time, which not only uses resources more efficiently and better, but also improves patient access and readiness. Reduces length of stay in the cardiovascular prep recovery area. So we work to keep predictability to the schedule, and we all know that that's not always possible, but we try to do it as best we can. It is still a little bit like herding cats when we do the TEs, but nonetheless. So we optimize and enhance the advanced practice through volume and experience. If you look at in 2009 when we did it, it was really just Roxy and I. We were performing 600 cardioversions a year, and now some of those were TE, but we cared for all of those patients, and so that was about 200 to 300 because Beth Hoffman then joined our team as well at that point. So for the Advanced Practice Directive Cardioversion Program outcomes, we worked with Dr. Strauss and Bradley on the HDI team to look at kind of the primary risk, and that's the risk of stroke within that 48-hour period of time. We have lower than national standards at 0.1 to 0.4. There's a growing number of procedures. Really that aligns with improving anesthesia resource utilization. We went from performing 4, maybe 6 cardioversions a day to now we can perform, I think I have 9 or 10 scheduled today. And improved access for patients as well as a growing practice throughout MHI as well as the EP program. By performing in more than one room, reducing length of stay and prep recovery, we can perform 3 to 4 cardioversions between the hours of 9 and 10 a.m. and those patients are gone, usually discharged by 10:30, 11 a.m. Through the lab. So, and then we also identify patients for antiarrhythmic therapy to better treat their symptomatic AFib, which sometimes will require returning for cardioversion. Over time, there has been, Stanford Health put out a study. It was described a program that was developed in 2012. This was a retrospective study from 2009 to 2014 and really was published in 2016. They looked at a total of 557 patients who underwent 869 cardioversions, and that was a 5.5 year period of time, which equates to about 160 cardioversions a year. And none of them were TEE guided cardioversions like what we do. All of them had the TEE beforehand, and then they presented for a second procedure to have the cardioversion. They all required anticoagulation for 1 month post-cardioversion, which is similar to what we do. And then long-term anticoagulation therapy was determined based on the CHADS-2 score. And they basically compared an MD-run cardioversion program, or cardioversion, not program, and an NP-run cardioversion. And the safety was defined, which is ironic because the safety actually was defined as no major short-term complications, which is stroke, MI, or death at the time that the patient discharged, which is about 3 to 4 hours after the procedure. So it wasn't, it didn't look further out than that. And really, the study demonstrated that an NP-run cardioversion is as safe as and effective as results comparable to that of an MD-run cardioversion. In looking through this and reading through it a number of times, really it clearly demonstrates we need to publish our program. As we have larger volumes, we have extended advanced procedures, safety, anticoagulation guidelines. I just put that in there because I know somebody's going to say it, and I know. So I always tell my children I'm kind of more of a doer than a talker or a writer. So anyway, so in summary, the guidelines and future directions for care in patients referred for cardioversion or cardiac monitoring. So really the anticoagulations. In 2009 when we started this program, the only agents on the market were warfarin and heparin. So really those were well defined. The 3 weeks anticoagulation, the TE guided if it's less than that. And then in 2011 the NOACs came, which they're no longer NOACs, right, because they're not novel, they're now DOACs. And really the community standard guideline was put in place. And at that point we used, again, like the acute and acute 2 trial, which is the TE and the heparin, and then the AHA, ACC, HRS guidelines, as well as we used UpToDate and the FIN cardiovascular study to put those together and with the EP team. So MHI cardioversion guidelines then aligned with findings that then came out in 2015 from a meta-analysis of patients undergoing cardioversions in the setting of DOAC. January of 2017, we utilized, Dr. Skake had published the overview of the direct oral anticoagulates in the MHIF journal. It was the first journal, first edition, as well as Dr. Moore, who had published the peri-on-peri procedural oral anticoagulation, using that all in consideration. And then our program actually participated in the EMANATE trial that looked at the safety of apixaban, and I can never say apixaban. I always say Eliquis, especially with a dry mouth. And then the vitamin K antagonist and heparin. So anticoagulation. This is a study that looked at patients who had newly diagnosed atrial fibrillation who needed to undergo a cardioversion procedure. This was actually just published in 2018. So the rates of stroke, systemic emboli, deaths, and bleeds were low for both the apixaban and the vitamin K antagonist-treated patients with AFib undergoing cardioversion procedure. The heparin protocol. Heparin protocol at Abbott has a therapeutic or a high intensity, and then they also have a low intensity protocol, which we a lot of times will call a heart failure protocol. The problem is that if a patient needed a cardioversion, the guidelines that we set up were based on heparin levels. Heparin levels weren't necessarily aligned to PTTs on the protocol, and so we would actually end up transitioning those patients to a high intensity heparin protocol for the cardioversion procedure, or we would perform the cardioversion as an exception to the rule, or we wouldn't perform the cardioversion at all, which would be only based on patient need, of course. But then we took a step back and we discussed with the MHI teams, which included EP and heart failure, and brought the concern to the pharmacy. So really the protocols remained the same, but then they actually opted to report out and align the PTT to the heparin level as well within the hospital, which helped us to better look at when we updated our cardioversion and anticoagulation guidelines, then we included the PTT. So really, we went based on research and what we know, and that the PTT needed to be 1.5 to 2 times the lab's control. This was vetted through the CVDS with the TE docs as well as the EP provider team, and now we can perform a cardioversion, or we facilitate providing a cardioversion to anybody with a PTT 55 or greater. And we don't always necessarily just go by the heparin level. The heparin hold, which is always part of the protocol, so if anybody has a high PTT, they would hold the heparin for 2 hours. And it's like inevitable. They would hold it for 2 hours at 2 or 3 in the morning, and then it would be subtherapeutic by the time we repeat it for our cardioversion, if the patient needed a cardioversion. And so basically that patient then had delay of care. What was nice is that Dr. Bradley actually encountered this as he was on hospital service one week and started the conversation and really started asking the questions. He worked with Matt Lillyblad and the pharmacy and really put forth an update to the heparin protocol, which ironically they were already looking at the peaks and valleys of that heparin protocol and were already looking to make changes as well. But a part of that they put to include a no hold for patients undergoing cardioversion procedure that same day, along with reducing the hold in those not having a cardioversion. And it was basically unanimously approved by clinical pharmacy leader, and the change was made, my understanding is June of 2018. The additional gray zones included things like the implantable loop recorder. Historically, the implantable loop recorder was actually the reveal. It was a conscious sedation procedure. It took 90 minutes in the EP lab. In the EP lab requires 2 EP techs, 1 RN, and an EPMD, which equates to 360 RVU times. I don't know if Nate Summers was just giving me a hard time in calculating this out for how they calculated RVU time, but basically it's the number of staff you had based on the number of minutes you're in the EP lab. The new technology of the link came out in 2014, and that really simplified the implant, and MHI adopted this to look at fiscal responsibility and how best to do this. So we actually moved the procedure to CV prep recovery. We use local anesthetic only. It takes 1 RN, which is Jane, Diane, and Liz will come in with us to hand sterile stuff, and then 1 advanced practice. The procedure takes less than 30 minutes, and the 30 minutes mostly is draping and trying to figure out how we're going to fold and do it without touching anything we're not supposed to touch. But in turn, actually implanting the link takes literally less than a minute. So it doesn't make sense to do it. And so we go from 360 RVU time to 60 RVU time. So then we developed, because about that same time in 2014, the Crystal AF trial came out, and that looked at patients with cryptogenic stroke and the incidence of atrial fibrillation, and found there was actually a high, there was a relationship between those two. But the timing wasn't consistent with what you could get on a telemetry monitor, a Holter monitor, or even a 30-day event monitor. It was usually an average time of about 85 days to diagnosis of the atrial fibrillation. And so we worked with Sherilyn Milner is now the current NP, and then Dr. Young, and really took that evidence-based medicine and started putting these implantable loop recorders in these patients with cryptogenic stroke, either prior to them leaving the hospital or upon return. And really, in 2014, we placed 34 Reveal devices. But by the ease of implant and us improving access to that, we now put about 200 links in annually since that time. So we've now passed our 4-year anniversary, and as many of you know, the life of the battery of the link is only about 3 years. And so when we were putting them in, everybody was asking, how are we going to take them out? We didn't have that answer at that point either yet. But when we put them in, our infection rate was less than 1%. We did have a few devices removed early, mostly for irritation. We did have one young lady who came in. She was like 1 day past her 18th birthday, and her mom, when she was 17, made her get the link, and so she was rebelling and insisted the day after she turned 18 and could make her own decisions that we take it out. We've had it where the diagnosis, of course, is made, and then we have well-endowed women who, as Dr. Gornick says, as we get older, the sands shift. Well, sometimes on well-endowed women, that sand shifts just as soon as they stand up. And so, so we've had to reposition a couple for that as well. We then took, our EP team took a look at it. That was Dr. Sengupta and Beth Hoffman. along with the MHIF intern. I believe it was Lena, right? And basically looked at our data from the implantable loop recorder placement in the cryptogenic stroke population. And we found that there was an average of 84 days to the time of detection of the arrhythmia. And really that changes patients' therapy. So they go from being on aspirin or Plavix to actually needing to be on anticoagulation. And we also found, consistent with the Crystal AF trial, that about 20 to 25% of our patients that are diagnosed with a cryptogenic stroke are actually found to have atrial arrhythmia on that LINC device. So again, the end of life came for the LINC, and we were putting them in, not really realizing how we were going to take them out. And so not knowing how to take them out, Gornick looks to us as there's 2 patients in prep recovery that day that need a LINC extraction or removal. And he says, well, if you can put them in, you can take them out. And so we go out and we together determine how we're going to take these LINCs out. And actually, we moved them all to prep recovery. They're all subcutaneously placed, so as long as we feel it, we put a couple of cc's of Epilido. We make a small 10 to 11 millimeter incision, and with the help of a hemostat, basically they come out. Concern was raised, again, always the questions, that we're not actually suturing that closed, we were just steri-stripping it closed, or butterfly band-aid concept. And so they're like, well, are they really healing? Are we having problems? So they suggested we bring 10 patients back, and Jane and Diane and Liz were so kind as to check all of those sites, and actually all of them had uncomplicated healing just with a little steri-strip. So again, a less complicated procedure with a good outcome. So dollars and cents, you could look at it as simple math. You can pay a cardiologist versus an advanced practice provider to perform a cardioversion or a LINC or a removal. And it's not just about that. Really putting the EPMD to perform those complex procedures for which their scope of practice is trained for, to improve access to care for patients, whether it's through the coming in for a cardioversion or a LINC, but also the EP lab availability for those complex procedures, and really expediting patients' access to care for easy scheduling and patient satisfaction. In regards to cents, we have safe patient care, there's patient access, efficient, optimal utilization of those precious resources. I mean, how many of us fight for anesthesia attention? Improved patient identification for advanced therapies, and the list goes on. So the take-home points really to take from this, really the role of the advanced practice, identifying practice needs within the gray zone and creating a systematic role to improve the healthcare delivery, identifying innovative cardiovascular care delivery through optimizing that provider scope of practice, which mirrors scientific discovery and understanding in a much better way than they did when they cracked tests to put a defibrillator or cardiovert people. And through this care, really identify guidelines and future directions for high quality and efficient care. Jacob took this picture of the Continental Divide this summer. Okay. Question? That's awesome. What's next? Generator changes. There's other practices that do diagnostic heart caths. They do right heart caths. They do electrophysiology studies. They do. There's one place that does pacemakers. I think that's a little. I'll hold off on pushing that one. Generator changes, though. There's a lot of things that we can do in this practice that really can get you guys to do the fun stuff. I mean, CTO and TAVR and mitral clip and tricuspid. Those are things I'm never going to do, but I can sure check the pressure of a heart and pocket. So, I talk fast. There you have it. All right. Other questions? No? All right. Thank you. And on your way out, please visit our sponsors. Today we have Brian and Lisa with Bristol Myers Squibb and Amy and Tamara.